AI is not going to replace doctors, but doctors who use AI are going to replace doctors who don't use AI. Cardiac diseases are a disease of the rich. In fact, the poor are more burdened than the rich. Many of the things that determine health go beyond the healthcare space. These concepts like life-work balance didn't exist when I was a young doctor. I mean, nobody thought about them. But get your thing that gets you out of the profession.
Welcome to Daktari Tone, where voices, perspectives, and sounds relating to healthcare practitioners and matters health are amplified. This is a podcast by Daktari Online, created for healthcare professionals across Kenya. Each episode brings you honest conversations, expert insights, and real-life stories from the front lines of care. Okay, welcome back. And we are grateful to have Dr. Ogolla with us, and we are deep into the conversations in cardiology. And to pick up, I have a fun question for you to ease on this episode out. What is the strangest patient request that you've ever received?
Nice. Let me think about that. Probably You know, it's one of those things we say thought block. I'm sure once I walk out of this room, I'll probably remember something very amusing. But let me think about it.
Yes, as we go on, if you remember, you just tell me. Yeah. So my first question for you is, what often do young medics get wrong, and how do you guide them? Okay,
so young medics here, we're probably talking of people who are undergraduates as they get into medical school.
Yes.
One of the things that I say get wrong in quotes, not exactly wrong, is really part of the growing up, is that one is that everybody who comes to medical school is brilliant. Our cutoff points is usually, even at A-, you're not guaranteed.
Yes.
So you see, if you get everybody who got A's together and they're 300, still one of them will be number one and the other one will be 300. And that is usually a demotivating thing for some of them. So you have to, get them through that and say, no. You've not become all of a sudden thick. You're quite. I think the other thing is that one of the issues, and this is really not about the students, it's about the structure, is that our selection criteria is purely based on academic performance. And obviously you need to be good in sciences to do medicine,
yes.
But it needs much more than that. And that's sort of sometimes is a culture shock for them, because probably because we don't have the instruments to test aptitude.
Yes.
So all we do is, do you have an A in maths? Do you have an A in physics? Do you have So it's something that the whole world is grappling with, because it is an important issue, but it's also very difficult to measure. Yes.
And now, taking you back, you mentioned so much about work-life balance. So you, as Dr. Ogolla, how do you deal, of course it's still continuous, how do you deal with burnout and pressure, and not to get into that part of I want to be perfect?
Well, okay, let me start from a historical point of view.
Okay.
This concept like life-work balance didn't exist when I was a young doctor. I mean, nobody thought about them. You are supposed to be in medicine, you work. I'll give you an example. I did my internship at the coast. There is the maternity at the coast is called the Lady Greg Memorial something. It's probably the second busiest maternity in Africa, after Pumwani, we have the distinction of having both of them.
Mm-hmm.
So we used to be, over the weekend, as an intern, you were left alone on Friday evening, and you're basically alone with the midwives until Monday morning.
Mm-hmm.
So it was terrible, and we had no opportunity to. So whether it was just that there was no choice, so we had to do it,
Mm-hmm.
or whether we were made of stellar stuff, I don't know. But you see, that's the sort of thing that we should not be, putting our young doctors through.
Mm-hmm.
So personally, I don't think I really have any particular, because it is everybody's thing. I mean, there are people who are sort of sporty.
Mm-hmm.
There are people who do it by, charitable activities, church activities, and all that. I think that the bottom line is get your thing that is totally divorced from the profession and do it. But let it not be alcohol or drugs.
What's your thing?
my thing is sort of varied. I think it's sort of broadly a socialization thing. I'm quite passionate about political issues and societal issues. I get a little time to exercise, probably not as much as I should. I'm like many Kenyans, fortunately or unfortunately, a TV football fan. So and all those things, but get your thing that gets you out of the profession. And I sort of mentioned alcohol in passing, and it's not really a joke, because what often happens is that in the middle of all these pressures, because the younger generation have got, like I said, more pressures than we had. I had a full-time, employment and sponsorship and what have you when I was doing postgraduate work. That is not guaranteed now. So we have very many young doctors who are probably paying for their training from their pocket. They don't have regular employment, so they are juggling jobs here and there. So, like, take the example of somebody who's being trained at the Kenyatta National Hospital. You have a full-time job there, and at night you are running from this hospital to the other. So very often the little time they have, sometimes then it is alcohol. So alcohol abuse is a real thing in our profession. It's not talked about much. But so those are the issues that we have to deal with.
Okay, that's really great advice, because there's this myth. It's not a myth. It's something that is going on, that most doctors would go for alcohol to suppress, pressures and burnouts and all that. And if so, Daktari, if you're not to be a cardiologist or in the cardiology profession, what would you be?
Should probably ask if I was not a doctor. I don't know.
Yes, if you're not a doctor, still in that area.
Well, probably a lawyer. Actually, many people who were in secondary school with me some of them actually surprised I ended up in medicine, because I used to see it now.
You would really make a good lawyer, though.
I used to be very good in debates and what have you and all that. So probably a lawyer. In medicine, if I wasn't a cardiologist, which of the other subspecialties? Probably diabetes.
Okay.
Yes.
Good to know. Now, on innovations and advances in cardiac care, what are those game-changing innovations that you've witnessed in your career?
Well,
that were not there in 1974. And now they're here.
I mean, you can't. It's not even the same. Whether you're talking of new drugs or new diagnostic capabilities or what have you, the way we manage, for example, something as straightforward as blood pressure now is completely different. Maybe I'll just highlight a few things. There's what we call cardiac ultrasound, what we call echocardiogram. You've probably heard about that term. I mean, somebody practicing cardiology now can't imagine life without an echo. After the time I was beginning postgraduate work, there was no echo. So you can just imagine the difference.
Yeah, it's making things more easy and faster.
Yeah, then the whole array of drugs, from drugs to treat blood pressure, drugs to treat heart attacks, and various things, drugs to treat cholesterol. There have been, and then what we call interventional treatment. For example, the treatment of a heart attack. The current treatment of a heart attack, for example, the idea that a heart attack is caused by a clot. So the immediate treatment of a heart attack must be by either dissolving that clot or physically removing the clot. That concept didn't get validated until 1986. So it's as recent as that. So there have been really major innovations. But let me just use this opportunity to talk about innovation in a different concept. Because often when we talk about innovation, and of course innovation is a current buzzword, every politician talks about it and all that, is we look at innovation in terms of some complex technical thing. I think we have to domesticate innovation to what it really is, to what it really is, which is, finding, English says you should use a word to define itself, but you'll excuse me here.
Okay.
But finding innovative ways to go around solutions. I mean, so if you are a medical officer in Mandera and you have all these guys with high blood pressure and you give them medicine and they don't take the medicine, so they come back to your clinic and the blood pressures are high, and it's because they are not. And if you work with them, with the community, to find a barrier as to why they are not taking their medicines and get them to take those medicines, that is innovation. So while of course the technical bit is important, we should also think about innovation, about finding unique solutions for unique problems where you live and where you practice. So maybe from an old man's point of view, that's what I wanted to add.
And from an old man point of view, one thing that I'm really, I can commend you on is you embracing new advancements, innovations, and even adapting to them. Because, you mentioning that we shouldn't take them as being complex or these things that we cannot get to really, your word is let's embrace them, get to learn them. If it's not working for us, we accept and move on to the next. That's what I'm getting, and that's really a commendable thing I'm noting. So I'll go ahead to policy, a policy kind of conversation, because you mentioned a lot of gaps earlier on, especially even when it comes to training and even the having less facilities that handle cardiology as a specialty. So what are these? You already mentioned them. What are your thoughts in national and institutional policies that you think should change?
Yeah. Okay, there are policies at healthcare, and then of course there are policies in terms of training. Obviously, the policy environment is extremely important. Because one is, we say prevention is better than cure, and if we're talking prevention, there's no private versus public and all that. Preventive measures are the same, and also a recognition that many of the things that determine health go beyond the healthcare space. For example, one of the issues we're having with is obesity in children. And obesity in children is driven by, one, the sort of foods they eat, and two, the lack of physical activity. So and this is where the policy environment comes in. If the school curricula is such that kids in primary school wake up at 4 a.m., by 6 they are in school. They are in class all the time, and they come back home at 6. They have homework to do. When do they get physical activity? over the weekends they are doing homework, and even if they wanted to exercise, especially in urban areas, the areas where they would exercise have been, to use the Kenyan term, grabbed to build
more houses and more spaces for people to live in.
So you see, that is a policy framework that goes beyond just health. It is education, it is physical planning, it is all that. I can tell you that it would be a good idea to cycle to work. For example, when you go to major centers in the Western world, CEOs cycle to work. But is it really feasible in our environment? We say eat healthy foods. Unfortunately, often healthy foods are more expensive than. So that then gets into agricultural policy, gets into financial policy, taxation, and all that. So the point I want to highlight here is that policies that impact health are actually policies that impact society. So our role as healthcare workers, especially as healthcare leaders, is then to play the role of advocacy, so that we highlight things that the final decision, unfortunately, it is not in our hands. It belongs to the policy makers and policy implementers. So basically, that is the politicians and the bureaucrats. But yes, we can make their seats hot enough for them to listen. And that's something that, for example, these organizations have said I belong to, the Pan-African Society of Cardiology, World Heart Federation. I'm quite an active member of the Kenya Cardiac Society. I was president 20 years ago, 25 years ago, actually. So all these things, and within Kenya, I can point to a few successes. One of the things is that working with the ministry, we actually have a national non-communicable diseases strategy. In fact, in the 1990s, we were very instrumental in creating, in fact, the first national communicable diseases. It was just a desk at that time. We worked, for example, another example is in practice of medicine, we have what we call guidelines. So if a patient comes with heart attack, how do you treat? If a patient comes with high blood pressure, how do you treat? We call those guidelines. Most of the guidelines are made in the Western world, and that's what our students read and all that. Sometimes the context is not the same. So again, in this context, working with the Ministry of Health, the Kenya Cardiac Society, we've made national cardiovascular guidelines that we made. The first lot, I think, is 2017. We've even had a revision which we published last year. So yes, that's our role, advocacy, to make sure that those things that are important to health get into national policy or global policy, of course. You probably know that there was this UN meeting, very important meeting in 2013, the UN high-level meeting on non-communicable diseases. It was only the second time that the UN, not the WHO, had a specific meeting for a disease after HIV. So this year is a repeat of that. So those are the places where you push the health agenda, where the politicians are.
And on pushing health agenda, just so that I don't miss it, I'm quite certain that accessing cardiac service or services is not cheap. So what are your thoughts on, accessibility, affordability, and even equity in cardiac services?
Absolutely important. Absolutely important, and that's one of the challenges that we have, especially in our country, where we have sort of a dichotomous healthcare service. So you have first world facilities in public health, in private care, and next no facilities at all in the public health sector, which means that then your health care is determined by your capability to pay rather than your needs. It's a difficult thing because, as you appreciate, this all goes towards all societal, a whole society sort of issue. But I mean, so we tackle it in several ways. Well, one, of course, start by prevention. Two, strengthen primary care, because a lot of these things can be preempted by a functioning primary health care. It doesn't need a cardiologist to treat blood pressure, to treat, elevated sugar and all that. You do that, you prevent the complications. And three, make sure that at least at a regional level we have centers of excellence in the public health sector that the ordinary mwananchi can pay, and ensure that there is access. And that's why, for example, a concept like SHA, if properly thought out, and this if is a capital if properly thought out and implemented, has got the potential in the sense that I just don't pay for myself. We pay all as a society to enable everybody who needs that to get it. But of course, implementation is an issue. So I think that's what I would say. And maybe the final word on that is then also decentralization, because you've talked of access. So access is not just financial, it's also geographical. If for example, there's something that exists only in Nairobi or Nairobi and Mombasa, and somebody's in Busia, somebody's in Migori, somebody's in Kwale, is in Garissa. So those are the issues that we can use to tackle access.
Okay. If you could talk about what you think about the future of cardiology in about 10 to 20 years, for you being even in so very many years in cardiology, and then a myth in cardiology that you think it needs to die.
A myth.
Yes.
Yeah.
And you also mentioned about reading, and you also in your adaptation to the new technology innovations and everything, and even the advice you give to the young medics is they keep on reading. So what is that one book or resource that every cardiologist should read?
Okay, so just remind me the first one.
The first one was the future, yes, of cardiology.
Obviously, there are technological advancements, both in terms of pharmacological advancements, what treatment in terms of interventions, what you can put into patients, what you can do in patients, but then also the use of technology to enable those advancements. So AI is coming in as a big thing, and obviously, like anything we are all protective of our territory. So anything that seems to be getting into your territory, there is obviously what I think is sometimes overreaction. AI is here with us. I mean, just like social media, it does a lot of terrible things, but we can't do without social media. It's the same thing with AI, as has often been put. AI is not going to replace doctors, but doctors who use AI are going to replace doctors who don't use AI. So that's a reality. I think prevention. It sounds sort of ironical that where we are talking of this fancy future, we're still talking of the basics. But prevention is still absolutely a fundamental thing. And maybe the other thing that technology should help us do is deliver care more efficiently. So it's not just the advances in the care, but how we are able to deliver the care. Yes.
Now a myth.
The myth.
Yeah.
That cardiac diseases are a disease of the rich. In fact, the poor are more burdened than the rich.
Yeah, actually, I attended the Matahatran, the Matahatran thing, and yes, of course, I met a lot of kids. The matter that when we're given data of how many kids even suffer from rheumatic heart disorders and many other names that I got to learn that they were a good number of very many kids are going through, cardiac disorders and diseases. Yes. Now, one book and resource that every cardiologist or medic should read.
Yeah. Can we? The problem is knowledge is advancing so rapidly.
Yes.
That in fact books as a source of technical knowledge have become irrelevant.
Yes.
Actually,
yes.
they have become. Yeah. So if you alerted me earlier, maybe I would have thought of a book which is more philosophical, because from a technical point of view, it is keeping up with the literature as it comes out.
Yeah.
And all these journals come once a week.
You can go into a resource, or somewhere I can go and get more knowledge. Yeah, as much as books are becoming coming out of, but anyway, they're still there, just being more.
So as if you're a cardiologist or for any healthcare worker for that matter, I think have a certain core group of journals that at least you have their content alert, because what is coming out, nobody can keep up with it. But at least have their content alert. Most journals are either once a month or once a week, so that you keep with what is going on. I mean, if it is something that is really in your territory or which is very fascinating, you pick it up, and then that's what I do. That's what I do. So that, I mean, like I say, the things that I get alerts about in a week, I couldn't read in a whole year. But at least I have it somewhere in my mind. If it comes, I say, oh yes, I know this one is in this journal, I'm going to follow it up. Yes.
Okay, so I'm going to wrap up from there. And Daktari, thank you so much for not only opening your heart in the clinical side, but also in your human side. Of course, both of them have human.
Yeah.
If you feel like I've left something out that you want to tell us more on cardiology, or even just the profession of being a doctor, and a medic, and even a professor and president and leader, there's a lot of leadership as well. And us trying to also bring together the integration of being in the medic space and leadership. And because getting even to say that, you mentioned a few examples where there's this type of profession where they'll say there's a lot of talking than hands, and so
Well, one, thanks for having me. And basically, I mean, this was not very structured from my point of view. I've sort of talked casually off the cuff, which I think probably comes out more naturally.
Yes, and that's the essence of it.
Yes. So I think to the young medics out there, and I would put it beyond cardiology. I think one of the things, as you grow older, especially with these leadership positions, then you begin to think more broadly rather than just and obviously these things are quite interrelated, because ultimately to deliver any care, you need a functional healthcare system. Yes. Maybe that's something that I didn't mention very explicitly. And a functional healthcare system has got nothing to do with cardiology or surgery or obstetrics. It needs to work. And I think most of the things we've said, and maybe the part, which of course is a very important part of my life that hasn't quite come out, is research, which is extremely important. And you can have, again, very high level, very sophisticated research, and that's well and good. We have to compete with everybody else. But research is really just about answering questions. And it's like what I said about innovation.
Yeah.
We need a lot of contextual research, which nobody else is ever going to do for us. So we need to do it. So it's also a plea for our systems to avail more resources for research, because almost all our research funding is coming from external resources. So to the young doctors there, yes, it is an exciting journey. Nothing good in life comes easily. It's always tough. It's something I usually tell newly married people, everybody tells you marriage life is difficult. Of course, everything good is difficult.
Yes.
So it is difficult, but it is manageable. Balance your life. Look at your practice medicine beyond the immediate clinical part. Look at it from a societal point of view. Volunteer for leadership positions, because these things don't pay, but somebody has to lead. And please inculcate also a culture of research, whichever practice environment you are in, because there's always something that you can add to the body of knowledge wherever you work. Yeah, I think I will stop here.
Thank you so much, Daktari. You've given us a rare and deep look into being a cardiologist, not only in Kenya, but in the world. And to you, our listeners, one thing that I've picked from Daktari is that nothing good comes easy. And I'm going to agree with that because my mom also says the same thing, but she also says, pick your battle. To our listeners, if you found this conversation valuable, please follow us on Daktari Tone podcast and catch us on our social media platforms. See you next.